Imagine a medical disaster, but the size of a single grain of sand.
Yeah, barely half a millimeter across.
Exactly. A blockage so microscopic you can barely even see it, yet it possesses the power to just instantly paralyze half of your body, leaving your face drooping, your arm totally lifeless.
This is genuinely terrifying when you think about the scale of it.
It really is.
Yeah.
So welcome to today's deep dive. We are exploring some incredible notes and excerpts from the 5 classic lacunar stroke syndromes out of the audio ward, and we're unpacking this genuinely fascinating, incredibly high-stakes medical puzzle.
Right, because when you or I hear the word stroke, we typically picture this massive catastrophic explosion in the brain.
Yeah, like a huge clot or a ruptured major vessel, like
Yeah.
whole lobes of the brain suddenly just deprived of oxygen.
Exactly. But today, our mission is to shift focus away from those massive explosions and take a close look at what I like to call the snipers of the vascular system.
I love that term, snipers. It just captures that clinical reality perfectly.
Well, it fits. Because we are talking about infarcts, which are areas of dead tissue that range from just 0.5 to maybe 15 millimeters in diameter.
Which is tiny.
It's microscopic.
Yeah.
And the footprints they leave behind are so highly specific, so meticulously localized, that recognizing them is an absolute diagnostic imperative.
Because misinterpreting these tiny surgical strikes is one of the most dangerous traps you can fall into in neurology.
Absolutely. It's a huge trap.
That sheer concentration of function is just what blows my mind here. We are talking about a microscopic blockage completely disconnecting a person's physical agency. So if these small-scale strikes are so devastating, where exactly are they hiding?
Well, to find them, you really have to look deep within the subcortical structures.
So definitely not happening on the outer surface of the brain.
Right, no. We are navigating far away from the wrinkled outer cortex, the gray matter where all your high-level thinking and language happens, and we're diving way down into the deep white matter.
So we're talking the basal ganglia, the thalamus?
Yep, the thalamus, and all the way down into the brainstem. These are densely packed regions that basically act as the primary thoroughfares for the entire nervous system.
And blood is getting down into those deep thoroughfares through what the sources call penetrating arteries.
That's right.
I have the notes here. It mentions branches off the anterior choroidal, the middle cerebral, the posterior cerebral, and the basilar arteries.
Yeah, so think of those as the major vascular highways of the brain. The penetrating arteries, on the other hand, are these tiny, delicate branches that shear off from those massive vessels at really sharp angles.
And then they just plunge straight into the deep brain tissue.
Exactly. They plunge directly down there to supply blood to very restricted, highly isolated zones.
Okay, let me try to visualize this for a second. So if the brain's vascular system is like a major city's water supply, the major arteries are those massive water mains running under the big avenues.
Right, the mains.
And if a main bursts, an entire neighborhood floods. That's your classic massive stroke. But these penetrating arteries, they are more like the tiny individual copper pipes leading off the main line directly into a single apartment unit.
That's a really great analogy, yeah.
So if that specific apartment pipe clogs, the rest of the building is totally fine, but that one specific room completely loses its water supply.
Perfect way to picture it. And because the rooms in the deep brain are essentially junction boxes for these massive fiber optic cables connecting the brain to the rest of the body.
Plunging one room into darkness just disconnects the entire system downstream.
Precisely. You lose the junction box, you lose the whole downstream network.
Okay, so if these tiny apartment pipes are so deeply embedded and isolated down there, what's actually causing them to clog in the first place? I mean, is it the same kind of plaque buildup that causes a massive heart attack?
Well, let's look at the patient case file provided in our sources.
Right, the patient who came in with a stroke.
Yeah. Their lab results showed an elevated HbA1c, which points to undiagnosed diabetes, along with a known history of chronic hypertension or high blood pressure.
So that specific combination is the trigger.
It creates a relentless pressure cooker for these tiny vessels. That combination of chronic hypertension and diabetes drives a very specific structural degradation over time.
Because the high blood pressure is just constantly battering the pipe.
Yes, exactly. When blood pressure remains uncontrolled over years and years, it physically batters the delicate walls of these small penetrating arteries. The sources highlight pathologies like fibrinoid angiopathy and lipohyalinosis.
Okay, let me just unpack that second term really quick. Lipohyalosis. So lipo obviously means fat. We're talking about a fatty buildup.
Right.
But hyaline usually refers to this stiff, glassy kind of protein substance. So this isn't just a soft blob of cholesterol sitting inside the pipe.
No, not at all. It's a fundamental remodeling of the pipe itself. The actual vessel walls become thickened, they get stiffened, and they're severely damaged by this toxic combination of lipid deposits and protein buildup.
So the wall loses its natural elasticity.
It does. It
Yeah.
loses elasticity, it narrows, and over time, that weakened, brittle wall might even bulge out.
Oh, like forming a microaneurysm.
Exactly, a tiny outpouching. And that creates turbulent blood flow in the pipe, which is just the perfect environment for a microscopic clot to form and completely seal off the vessel.
Wow. But that sounds like a very long-term wear and tear kind of issue. What if a patient doesn't fit that profile?
What do you mean?
Like, if you have pristine blood pressure and zero diabetes, are you just immune to these deep brain snipers?
Oh, no, that assumption is a very dangerous one to make.
Early.
Yeah. While accelerated hypertensive damage is the classic narrative, it is far from the only threat here. A patient can develop microtheroma, which is basically a tiny atherosclerotic plaque forming right at the origin where the small penetrating branch shears off the main artery.
Ah, so essentially blocking the doorway to the apartment before you even get in.
Exactly. You also have to consider arterial or cardiac embolisms.
Like a clot from the heart.
Right. A tiny fragment of a clot could break off from the heart, travel all the way up the main highways, and just lodge itself tightly right into that small pipe.
That is terrifying.
It is. Even hemorrhagiological changes can cause it, meaning an increase in the thickness or the viscosity of the blood itself can just cause a blockage in a narrow space.
Okay, so the apartment pipe can narrow from chronic pressure damage. It can get blocked at the entrance by a plaque, or get plugged by microscopic debris just floating downstream.
You've got it.
But regardless of how the blockage actually happens, the end result is a tiny zone of cell death. And because the deep brain is wired with such extreme density, taking out just a half-millimeter section produces these highly predictable, almost robotic physical responses.
The clinical presentation is remarkably consistent. I mean, the medical vault describes over 20 of these highly specific syndromes, but our sources note that 5 of them really dominate the clinical landscape.
The 5 classic footprints.
Exactly. And the most frequently encountered one is pure motor hemiparesis.
Pure motor, meaning absolutely no sensory loss whatsoever. Like, the patient can feel a pinprick, they can feel a cold stethoscope, but they just cannot move their body.
That's it. The patient presents with unilateral weakness affecting the face, the arm, and the leg simultaneously. And often it's accompanied by some mild dysarthria, so some slurred speech.
And anatomically, where is the sniper hitting to cause that?
This happens when the tiny stroke hits areas like the basis pontis in the brainstem or the internal capsule or the corona radiata.
The corona radiata, I always thought that term sounds like some sort of celestial event.
It really does sound like that.
But visually, it's this massive fanning crown of white matter nerve fibers coming down from the surface of the brain, right?
The visual of a crown is perfect, yeah. All the motor signals originating from the vast surface of the brain have to funnel down into this tight, narrow bottleneck, which is the internal capsule, before they can travel down the spinal cord.
Right.
So if a half-millimeter sniper hits that specific bottleneck, it severs the bundled wires for the face, the arm, and the leg all at once.
It's just astonishing to think about. The wires controlling your ability to smile, to wave your hand, to walk, they are bundled so tightly together that a single drop of dead tissue takes them all out simultaneously.
It's incredible.
But what happens if the sniper hits, say, a few millimeters away? Like bypassing the motor wires entirely and striking the sensory wiring instead?
Then you see the exact inverse. You get a pure sensory stroke.
Okay, so where does that happen?
This localizes to the vetroposterolateral nucleus of the thalamus.
That's a mouthful.
Yeah, the VPL thalamus. The thalamus acts as the grand central station for sensory input. When a tiny stroke hits this specific relay nucleus, the patient experiences sudden paresthesia, numbness, and a one-sided sensory deficit.
So they can move their arm and leg perfectly fine, but half their body just feels entirely alien to them.
Exactly. They have total motor control, zero sensation.
Now, I noticed in the notes, though, that a pure sensory stroke is considered the least predictive of true lacunar disease. Why that specific caveat?
That's a great catch. It's because the brain's architecture allows for mimics.
Mimics.
Yeah. A cortical infarct, So a stroke up on the outer surface of the brain, specifically hitting the postcentral gyrus, where sensory information is ultimately processed, that can produce an identical clinical picture.
Oh, I see.
So if a clinician sees pure sensory loss, they cannot confidently assume it's a tiny, deep brain sniper. The damage might actually be a much larger surface issue that's just masquerading as a lacunar.
That makes total sense. It's kind of like trying to figure out if your internet is down because of a broken router in your own living room, or if a power line is down a mile down the street. The symptom looks exactly the same on your computer screen.
That is exactly what it's like.
Okay, so we have pure motor, pure sensory. Now, if we combine those two geographic zones, I'm assuming we get the sensorimotor stroke.
You do. The pathology here hits the posterior limb of the internal capsule and extends right into the thalamus.
Because they're right next to each other.
Right, because these structures sit directly adjacent to one another.
Yeah.
So a slightly larger but still very small lacunar stroke can wipe out both the motor bottleneck and the sensory relay station in one shot.
Leaving the patient with contralateral motor weakness with a superimposed hemisensory deficit on that exact same side.
Exactly. Both movement and feeling are compromised.
Okay, so we've covered the clean divisions, pure motor, pure sensory, and the combo. But the deep brain isn't just about raw power and feeling things, right? It's also about coordination.
Yes.
And that brings us to a syndrome with a highly specific, almost weirdly descriptive name, dysarthria clumsy hand syndrome.
The focal nature of this one is just extraordinary. It localizes deep within the basis pontis.
Down in the brainstem.
Right. The patient suddenly develops supranuclear facial weakness, severe dysarthria, dysphagia, trouble swallowing, and a very pronounced loss of fine motor control, specifically in the hand.
Just the hand.
Mostly the hand, yeah. And you'll also typically find a Babinski sign.
That's the abnormal upward reflex of the big toe, right? When you scrape the bottom of the foot.
Yes, which indicates damage to the central nervous system pathways.
Just think about the sheer precision required for a biological event to selectively dismantle a person's ability to articulate words and perform fine hand movements, but leave their broader limb strength largely intact. It's wild.
It really highlights how specialized these small regions are.
But as fascinating as that one is, I really want to spend some time on ataxic hemiparesis. Because looking at the notes, this one presents a totally bizarre clinical paradox.
Oh, the contradiction is exactly what makes it so defining.
So what's happening here?
The stroke typically occurs in the internal capsule, or the basis pontis. The patient experiences weakness, primarily in the contralateral leg. But stacked on top of that weakness is severe ataxia, which is in coordination, affecting the arm and the leg on that exact same side.
Okay, let's ground this for a second so you, as a listener, can really picture it.
Yeah.
Imagine you are trying to drive a car where the engine is just sputtering and dying. Right.
Right.
You can barely get up to speed. That represents the hemiparesis, the profound weakness and lack of power in the limb. But at the exact same time, the steering column is completely detached and rattling around.
That's the ataxia.
Exactly, the total loss of coordination. So you're trying to manage a dying engine and a broken steering wheel on the exact same side of the vehicle, all caused by one tiny mechanical failure. Neurologically speaking, how is that even possible?
It comes back to that concept of the bottleneck we talked about earlier.
Right.
In these incredibly tight subcortical spaces, the descending motor fibers that give the leg its raw power are running mere micrometers away from the corticopontocerebellar fibers.
And those are the coordination wires.
Right, those are the pathways that communicate with the cerebellum to coordinate smooth, accurate movement. So when a tiny stroke hits that specific microscopic junction, it clips both sets of wires at once.
So a patient might have a leg that's so weak they're literally dragging it across the floor, but if you ask them to lie down on a bed and smoothly run that same weak heel down their opposite shin, they wildly miss the target.
Exactly. The weakness and the clumsiness exist simultaneously in the same limb.
That is so strange.
It is. And what is vital for the listener to understand is that a clinician shouldn't look at that paradox and try to rationalize it away. You don't guess whether the patient is mostly weak or mostly clumsy.
The paradox itself is the clue.
Yes. The paradox is the diagnostic fingerprint. Weakness plus ataxia on the same side immediately points the compass straight toward ataxic hemiparesis.
Wow. Okay, so pure motor, pure sensory, sensorimotor, dysarthria, clumsy hand, and ataxic hemiparesis. The 5 classic footprints.
Those are the big 5.
But reviewing the sources, it seems like the ultimate key to diagnosing a lacunar stroke isn't just identifying which of these symptoms are present, The real test is aggressively hunting for the symptoms that are missing.
That is the golden rule of exclusions in vascular neurology.
The golden rule. I like that. So what's the rule?
To confidently label an event as a true lacunar stroke, there must be a total, unequivocal absence of cortical signs.
Cortical signs, meaning clear evidence that the outer surface of the brain, the cortex, where our highest level processing occurs, is under attack.
Exactly. If the patient exhibits aphasia, which is any loss or impairment of language, it is not a pure lacunar stroke.
What else?
If they show apraxia, where they lose the ability to perform learned, purposeful movements despite having the physical strength to do them, or if they have agnosia, where they are suddenly unable to recognize familiar objects or faces.
Or visual field loss, right?
Yes, visual field loss too. The presence of any of these signs immediately rules out a microscopic deep brain sniper.
This actually circles perfectly back to the case file we looked at earlier. So the patient came into the ER with facial drooping and arm weakness.
Right.
And at first glance, that looks remarkably like a pure motor lacune, right? The deep brain apartment pipe clogged, taking out the motor bottleneck.
It looks exactly like it on the surface.
But then the clinical update noted that the patient also had language involvement. They couldn't speak properly or comprehend instructions.
And the instant language impairment enters the clinical picture, the entire paradigm shifts.
Right, because language isn't processed in the basement wiring of the brain. Language is a very high-level surface brain function.
Exactly.
So the moment the patient couldn't communicate, it became glaringly obvious that we weren't just dealing with a tiny apartment issue. A major avenue on the surface was blocked. The whole city block was flooding.
The presence of true cortical dysfunction tells you that a much larger, much more dangerous threat is active. And understanding this distinction transitions us into what is arguably the most critical aspect of this entire discussion.
The diagnostic trap.
Yes, the diagnostic trap. Misinterpreting these signs is not merely some academic error. It has devastating real-world consequences for the patient.
Because if you brush this off as a tiny event when it's actually something massive, the patient is essentially sitting on a time bomb.
Exactly. The most dangerous trap a clinician can fall into is diagnosing a lacunar stroke solely based on a classic symptom profile and a patient history of hypertension and diabetes, while failing to investigate the larger cardiovascular system.
Okay, let me play devil's advocate here for a second.
Go for it.
If it walks like a duck and it quacks like a duck and the patient has all the right risk factors for a duck, why is it a trap to just diagnose the duck and move on?
Because in vascular neurology, a massive, lethal predator can very easily wear a duck mask.
Oh, wow. Okay.
Let's say a patient presents with a classic sensorimotor stroke, sudden weakness and numbness on one side. The clinician might assume a small lacune hit the internal capsule and thalamus. They attribute it to the patient's diabetes causing small vessel disease, prescribe some medication, and discharge them.
Seems reasonable.
But they failed to actively investigate for cardioembolic sources.
A clot factory in the heart.
Exactly the threat we are looking for. Consider a patient with undiagnosed atrial fibrillation.
A fib.
Right. The upper chambers of their heart are fibrillating. They're quivering instead of beating rhythmically. Blood pools in the heart, it stagnates, and it forms massive clots. If a small fragment of that clot breaks off, shoots up the carotid artery, and just happens to wedge itself in a deep penetrating artery, it will perfectly mimic a small vessel lacunar syndrome.
But the underlying cause isn't small vessel disease at all.
Not at all. The underlying cause is a massive clot generator sitting right there in the chest. If the clinician just assumes it's small vessel disease and sends the patient home, that patient still has atrial fibrillation.
And the very next day, they could fire off an even bigger clot.
The next day, that heart could fire off a massive clot that blocks the entire middle cerebral artery, causing a catastrophic, life-ending stroke.
That is chilling.
You can also see this with severe carotid artery stenosis. The main highway in the neck might be 90% blocked by plaque, and the first clinical symptom just happens to look like a tiny deep brain stroke because a tiny fragment flaked off. But in reality, the entire system is on the verge of total collapse.
So these large striatocapsular infarcts or sensorimotor strokes aren't just fascinating anatomical puzzles. They are massive red flags screaming at the clinician to look at the heart and the major arteries.
They absolutely are.
The mindset required here seems incredibly intense. I mean, if you are a medical professional or just a deeply curious learner listening right now and trying to grasp the stakes of this environment, what is the governing philosophy?
The governing philosophy must be guilty until proven innocent.
I love that.
When a patient presents with a small neurological footprint, You cannot passively assume it's just a tiny lacunar caused by localized wear and tear. You must aggressively prove, beyond a shadow of a doubt, that a massive cardioembolic threat isn't waiting in the wings.
So you do all the tests.
You demand an EKG, you image the carotids, you scrutinize the heart. Only after you have rigorously cleared the major vascular highways can you safely drop your guard and manage it as a true lacunar infarct.
And once you've proven that innocence, once you know for sure it's just the localized pressure cooker problem, how do you actually manage it? We know we can't reverse the dead tissue, right?
Right, the damage is done.
So the focus shifts to preventing the next sniper shot.
Exactly. Management aggressively targets the underlying mechanics of the damage. We enforce strict blood pressure control to immediately stop the physical battering of those delicate subcortical vessel walls.
Turn down the pressure cooker.
Yep. We initiate intensive statin therapy, and not just to lower cholesterol, but to actively stabilize the vascular endothelium and address that lipohyalinosis we talked about.
Right, fix the stiff, glassy pipes.
And we use platelet antiaggregants like aspirin to make the blood less viscous, which prevents tiny clots from forming in those dangerously narrowed pipes.
It is just an incredible sequence of deductive reasoning from start to finish. Let's bring all these threads together for a rapid-fire recap of today's deep dive.
Sounds good.
We started by conceptualizing the sheer power of these microscopic blockages, tiny vascular snipers operating deep in the subcortical basement of the brain, driven by a toxic pressure cooker of chronic hypertension and diabetes that literally remodels and destroys the small penetrating arteries.
And we detailed the 5 classic footprints generated by those strikes, right? Pure motor hemiparesis targeting the descending motor tracts, pure sensory stroke hitting the thalamic relay station,
Sensorimotor stroke overlapping both regions.
the intensely localized dysarthria, clumsy hand syndrome in the pons, and the diagnostic paradox of ataxic hemiparesis, where weakness and severe clumsiness overlapped on the exact same side because motor and coordination pathways are bottlenecked together.
We also established the golden rule of exclusions. True lacunar strokes are entirely silent on the surface of the brain. If there is aphasia, apraxia, visual field loss, or agnosia, you are dealing with a surface-level crisis, not a deep brain apartment issue.
And we closed with the ultimate diagnostic trap. A small footprint never guarantees a small cause. A clinician must relentlessly rule out major cardioembolic threats like AFib or severe carotid stenosis with a guilty until proven innocent approach.
Before finalizing a diagnosis of small vessel disease and initiating that targeted prevention,
Exactly.
it is truly a masterclass in mapping the invisible. But before we sign off, I want to leave you, our listener, with a thought to mull over. We began by talking about precision and how we naturally crave clear-cut binary answers like seeing a broken bone on an X-ray. But think about the staggering implications of what we've just uncovered today. If a biological failure the size of a single grain of sand, barely half a millimeter across, can reliably, consistently, and identically shut down the exact same highly specific combination of human functions across thousands of wildly different people, what does that reveal about the sheer mechanical precision of how our brains are actually wired?
It's a huge question.
We love to romanticize the human mind. We like to think of our consciousness as this uniquely abstract, fluid entity floating somewhere above the rigid laws of the physical world. But at its core, this deep dive proves that your brain is a meticulously, brutally hardwired machine, where every single microscopic millimeter has a non-negotiable purpose.
It really humbles you.
It does. The sniper doesn't just reveal the hidden vulnerabilities of our vascular system. It strips away the illusion of fluidity and reveals the breathtaking microscopic architecture of exactly who and what we are.
Beautifully said.
Thank you so much for joining us on this deep dive. We'll catch you on the next one.